Hello, my name is Mary O'Neill, and I'm going to be doing the board review for neurology today. I have no disclosures. So the first question is a 47-year-old hiker who has pain in his left buttock that radiates down his left leg. The pain is not affected by position or motion. She also says that her left foot tingles, as do parts of her leg and thigh, left fingers, and left anterior portion of her chest. A month ago, a physician treated her for right Bell's palsy and arthritis. So question number one, which of the following would be the most helpful in establishing a diagnosis? A, an EMG, nerve conduction study. B, a somatosensory evoked response. C, an MRI of the spine and spinal cord. D, a lumbar puncture. Or E, a lumbar spine X-ray. The answer is D. So this lady obviously has Lyme disease, which can present with cranial neuropathies. Typically, seventh nerve palsy is very common and occurs in up to 10% of untreated patients. And it also causes an inflammatory polyradiculopathy, which can mimic a mechanical radiculopathy, such as from a disc herniation. So a lumbar puncture would rule out other inflammatory infectious disorders and would be classically showed with lymphocytic pleocytosis. An EMG nerve conduction study might be abnormal, but wouldn't help be definitive in making the diagnosis. And an MRI would be abnormal, particularly if you did it with gadolinium, but again, would be not specific. And an X-ray of the spine would not be helpful at all. Question two, a 78-year-old woman who's a normal tensive suddenly cannot see to the left and notes that her left hand is tingling. 2 years previously, she had a stroke, which left her right side weak. And the family report that during the past years had been a bit unreliable in daily responsibilities and forgets people's names. A CT scan shows a recent well-circumscribed homogeneous right parietal temporal hemorrhage, as well as an old slit-like cavity in the left medial frontal lobe under the cortex, ventricular dilatation, and some cortical sulci widening or atrophy. So the most likely diagnosis is A, hemorrhage into a brain tumor. B, cerebral amyloid angiopathy. C, embolization of cardiac origin with hemorrhagic infarction. D, multiple cerebral aneurysms. Or E, recurrent head trauma. The answer is B, cerebral amyloid angiopathy. So here's a picture of her CT scan where you can see the well-circumscribed hemorrhage. And in the left frontal lobe, there's an area of old slit-like hemorrhage. So her prior stroke that resulted in the right-sided weakness is explained by the left frontal lobe lesion. And this slit-like cavity is often seen as a residual finding after a hemorrhage. So this is a lady who's had two unprovoked hemorrhages in a lobar location with possible dementia given the family history. And so this is most consistent with cerebral amyloid angiopathy, which intracranial hemorrhage is is a very common recognized complication. Question three. After skiing, a 27-year-old woman develops pain in the mastoid region that radiates to the left occiput and neck. The next day, she becomes dizzy, staggered, and felt pain in her forehead and eye. On physical exam, she has a normal blood pressure, but she has some abnormal neurologic findings, including decreased pin perception on the left side of the face and right trunk. She has a left Horner syndrome, rotatory nystagmus, weakness of the left palate and pharynx, and clumsiness and incoordination of the left limbs. So the most likely diagnosis is A, embolus to the basilar artery with pontine infarction, B, pontine hemorrhage, C, dissection of the left vertebral artery, D, dissection of the left internal carotid artery, or E, atherosclerotic occlusion of the internal carotid artery. The answer is C, dissection of the left vertebral artery. So vertebral artery dissection commonly presents with ipsilateral, occipital, or neck pain, and patients often point to the exact location of the dissection. And in this case, she had a lateral medullary stroke, or the eponym is the Wallenberg syndrome, which is a medullary stroke, which is shown in the DWI image up here, involving the lateral medulla, which causes cross-sensory findings, cerebellar findings, ipsilateral horners, weakness of the pharynx and larynx related to cranial neuropathies, leading to causing dysphagia, dysarthria, and vertigo. So question 4. A 64-year-old man has progressive spasticity of gait, impotence, and urinary frequency. He has occasional headaches at the vertex. Physical exam shows increased tone in both lower extremities, 3+ patellar and ankle reflexes, and bilateral extensor plantar reflexes. Which of the following is the next best step in his care? 1, A, sending him to physical therapy. B, magnetic resonance imaging of the cervical spine. C, an EMG nerve conduction study. D, CT scan of the lumbar spine. Or E, cerebral angiogram. The answer is B. An MRI of the neck is the test of choice to assess this gentleman because he has a cervical myelopathy. Cervical cord compression, as shown in this sagittal MRI, can cause progressive spasticity, sexual dysfunction, and spastic bladder. The most common etiology for this disorder in the elderly is cervical spondylosis. And signs of cervical canal narrowing can be seen on plain films, CT, MRI, or CT myelogram, but an MRI is the best test here. An EMG nerve conduction study is rarely useful, but as it only looks at root problems or peripheral nerve pathology. So question 5. An 80-year-old woman with mitral valve disease and chronic atrial fibrillation suddenly becomes confused during a family dinner. She's awake, alert, and her motor function seems to be intact. She's moving everything symmetrically. She speaks in long sentences unconnected to the events of the evening or the questions asked of her. She uses many word substitutions and nonsense words. She appears unable to understand questions put to her by her family members. The most likely diagnosis is A, complex partial seizure, B, transient global amnesia, C, a dominant hemisphere stroke, D, non-dominant hemispheric stroke, or E, delirium. The answer is C. This is a dominant hemispheric stroke. She has risk factors with atrial fibrillation and has sudden onset of deficits characteristic of a stroke. Her language is consistent with fluent speech with word substitutions, which we call paraphasia, and nonsense words, neologisms. She has impaired comprehension, and this is sort of a very classic description for Wernicke's aphasia. It localizes to the left hemisphere, involving the posterior temporal lobe, which is Wernicke's area. There are no motor deficits because the inferior portion of the middle cerebral artery does not supply the frontal lobe or motor cortex. Sometimes there may be a visual field deficit associated with this, involving the optic radiations. And so, but that can be very difficult to elicit if someone has a significant aphasia. 95% of right-handed people will have a dominance of the left hemisphere for language. Question 6. A 48-year-old man comes to his physician complaining of right leg pain and numbness for the past 3 weeks. Pain is in the upper lateral thigh. It's burning and stinging in quality. The pain radiates to the groin and down to the knee. He has a past medical history of obesity and has not seen a doctor for many years. On examination, he's obese, otherwise well-appearing. Strength is full bilaterally. There's decreased sensation in his right lateral thigh to temperature and pinprick. There's also a decreased sensation to pinprick, temperature, and vibration bilaterally in a stocking distribution to the mid-calves on both sides. Reflexes are notable for 1+ knee jerks, no ankle jerks, and bilateral flexor plantar responses. So which is the next best diagnostic test to obtain? A hemoglobin A1C, B, a vitamin B12 level, C, an EMG nerve conduction study, D, an MRI of the lumbar spine, or E, a CT scan of the pelvis. The answer is A. So this gentleman has what we would call myalgia paresthetica, this is really a neuropathy that affects the lateral femorocutaneous nerve. A nerve is often compressed by tight clothing. It can also be associated with weight gain, where compression at the groin. Also, significant weight loss can cause this condition, presumably by decreasing the fat padding around the nerve. The diagnosis is a clinical one by finding the typical sensory loss as demonstrated here, which respects the midline with normal motor function. It is very common in patients with diabetes. And in this patient, he has a peripheral neuropathy as well, likely related to undiagnosed diabetes. A B12 deficiency causes a myelopathy as well as a neuropathy, and it would not present as in this case. Okay, question 7. 10 days ago, a 22-year-old man had an inoculation of tetanus toxoid in his right arm after removal of a splinter. He now has severe pain in his right shoulder and arm, as well as paresthesias in his right hand. On physical exam, he has severe weakness of muscles around the right shoulder girdle and absence of a right biceps reflex. Passive movement of the shoulder is normal. Sensory exam is normal, and other reflexes in the arms and the legs are normal. The most likely diagnosis is A, a brachial neuritis, B, a herniated C7 disc, C, epidural cervical spinal abscess, D, a cervical spine tumor, or E, a rotator cuff injury. The answer is A, brachial neuritis. This is called a Parsonage-Turner syndrome, is characterized by inflammation of the brachial plexus, typically coming on after immunization. It presents with severe shoulder pain And then after the pain starts to improve, there's generally weakness, particularly in the upper plexus, that is deltoid and periscapular muscles. It can occur in an idiopathic fashion, but it also can be autoimmune and triggered by immunization, as in this case. Typically, there's a good recovery. Treatment is supportive. There's no role for steroids or other immunosuppression. A C7 disc would not cause weakness in the distribution, as in this case, and it would cause a weakness in the triceps and wrist extensors, but it wouldn't cause a dropped biceps reflex or proximal shoulder weakness. Question 8. 60-year-old man with a long history of back pain recently began feeling weakness and tingling in his legs when he walks more than half a block. The symptoms disappear when he sits. He has no symptoms when he does bicycling-like exercises supine on his bed, even after 30 minutes. Except for an absent left ankle jerk, his neurologic exam is normal. Foot and femoral pulses are also normal. The most likely diagnosis is A, aortic atherosclerosis with claudication, B, a polyneuropathy, C, a disc herniation at L5, D, lumbar spinal stenosis, or E, cervical spondylitic myelopathy. The answer is D. So this is a great history for what we call neurogenic claudication. So lumbar stenosis can be asymptomatic, but is often associated with low back pain and causes signs and symptoms of focal nerve root compression, or can give rise, in this case, to neurogenic claudication, which is pain and discomfort in the low back, buttock, and legs that occurs only after walking and is relieved with sitting. Relief of the symptoms when you're flexed is typical, which is why it's easier to walk up a hill rather than downhill, and forms the basis of what we described as the bicycle test. So because you should be able to perform well with the spine flexed and have more difficulty with being in the upright or erect position. Patient with vascular claudication would not be different in a patient with vascular claudication. And again, he had normal vascular pulses. So question 9. A previously healthy man is found unconscious in his apartment, and there's no evidence of trauma. On examination, he is responsive to voice and painful stimulus, but there's no evidence of any meningeal irritation. Pupils are 3 millimeters and unreactive. There is no inducible eye movements by the oculocephalix or Dahl's maneuver, or even with irrigation of the tympanic membrane with ice water. Blood pressure is 90/70, pulse rate is 54, and respiratory function is depressed. The most likely diagnosis is A, a sedative drug overdose, B, subarachnoid hemorrhage, C, intracranial mass, D, a brainstem stroke, or E, narcotic overdose. The answer is E, narcotic overdose. So the clues are that he has small pupils and a depressed respiratory rate. So a patient with impaired brainstem function it certainly can happen after temporary drug overdose. Both sedative and narcotic overdose can lead to absent oculocephalic and ocular vestibular reflexes. The pupils wouldn't be small, though, in a sedative drug overdose. Question 10. A 35-year-old woman had a renal transplant 4 years ago for renal failure. due to membranous glomerulonephritis. She's hospitalized because of progressive left-sided weakness and dysarthria. She has been treated with prednisone and cyclosporin. A test for HIV is negative. MRI of her brain shows in the right frontal lobe a focal abnormal signal that spares the cortical gray matter, as shown here. There is minimal mass effect and no enhancement of this lesion. There's also similar small lesions throughout the white matter. So, the most likely diagnosis is A, multiple sclerosis, B, a glioma, C, an embolic stroke, D, progressive multifocal leukoencephalopathy, E, primary central nervous system lymphoma. The answer is D, progressive multifocal leukoencephalopathy. Patient is immunosuppressed, leaving her very vulnerable to activation of the JC virus. This disease is usually associated with AIDS, but also can be seen in other patients with immunocompromise. The virus causes destruction of the CNS white matter by infection of the oligodendrocytes. With acute lesions of multiple sclerosis, the glioma and the lymphoma, there would often be enhancement due to breakdown of the blood-brain barrier. Additionally, MS would require two separate episodes of demyelination in time and space, and this patient wouldn't be at any higher risk for MS than anybody else. A stroke would affect the gray matter as well as the white matter, and would not present in this fashion. So question 11. The diagnosis can be best established by A, measuring beta-2 microglobulin in the CSF, B, an EEG, C, arteriography, D, MRI imaging, or E, brain biopsy. So the answer is E, brain biopsy. Diagnosis of PML can be made by CSF PCR, which is highly specific, up to 92%, 92 to 99%, and sensitive, 74 to 93%, for detection of the JC virus in patients with PML. The brain biopsy also is quite sensitive, up to 92%, but very specific, up to 100%, showing viral inclusions. Question 12. A 60-year-old businessman suddenly becomes confused at a meeting. He has no perceivable motor impairment and recognizes his colleagues. He continually asks the same question over and over again about the subject matter under consideration at the meeting. 1 week later, the patient's normal but unable to remember the events of the meeting at all. So the most likely diagnosis is A, a hysterical fugue state, B, a pulmonary embolus, C, a stroke syndrome, D, transient global amnesia, or E, a complex partial seizure. The answer is D. Transient global amnesia, or TGA, is characterized by less than 24 hours inability to make new memory. They have antegrade amnesia, cannot be attributed to other causes such as a stroke or seizure. They have normal level of awareness and otherwise normal cognitive functioning during the event. Characteristically affects middle-aged or elderly people. They have a very classic presentation, in this case, where they repeat over and over again the same question. The underlying cause is not clear, but it's thought to be related to reversible dysfunction of the hippocampus, probably due to ischemia or excitotoxicity. Question 13. 4 years after having a lumpectomy and radiation treatment for breast carcinoma, a 45-year-old woman develops pain and weakness of her left leg that spreads over a week to involve her right leg. She has low back pain in the mid thorax and a circumferential band like sensation. In the past day, she's become incontinent of urine after brief urgency, and genitalia are numb. She weighs 160 kilos. Reflexes are 3 plus with unsustained ankle and knee clonus. Toes are extensor, and the legs occasionally jerk in a flexed position. So, the most likely diagnosis is A, intramedullary metastasis, B, an epidural metastasis, C, carcinomatous meningitis, D, metastasis to the sagittal sinus, or E, radiation necrosis of the spinal cord. The answer is B, epidural metastasis. So she has core compression in the thoracic region, causing her this radicular pain and circumferential numbness. And then she has lower extremity weakness with bowel and bladder dysfunction, saddle anesthesia. This is a neurologic emergency. The most common metastases leading to cord compression are prostate, lung, and breast cancer. And the metastases usually begin in the posterior aspect of the vertebral body with later invasion of the epidural space. And the most common early complaint is pain. 2/3 of the patients will have motor deficits at the time of the metastasis diagnosis. Question 14. A 25-year-old woman has lost vision in the right eye for 6 weeks at age 18. The loss was attributed to, quote, nerves when her father died. Her visual acuity had been as bad as 20/400, but now it's 20/20 with 20/15 acuity in the left eye. She's been having recurrent 20 to 30-minute episodes of dimming of vision related to exercise and hot showers, and she has no other neurologic symptoms. Which of the following statements about this patient is or are true? A, she has a larger pupil on the right. B, she probably has a normal visual evoked potential. C, she has a right afferent pupillary defect. D, she has definite multiple sclerosis. Or E, she has an optic nerve tumor. The answer is C. She would likely has a right afferent pupillary defect. So her initial presentation was consistent with an optic neuritis, which would be associated with an afferent pupillary defect, meaning that she had poor visual acuity out that eye, so that that when you shine the flashlight back and forth, that there'd be a relative dilatation of that pupil. So optic neuritis is the presenting symptom of multiple sclerosis in up to 50%. And she also has his Utah's phenomena. This is this episodic transit worsening of symptoms with increased body temperature, either due to exertion or in her hot showers. And it occurs with isolated optic neuritis and in patients who have had optic neuritis associated with multiple sclerosis. So 6 months later, she returns after having an episode of right leg weakness and numbness that resolved. MRI at that time shows an enhancing lesion of the left periventricular white matter. She begins treatment for MS, but develops fevers, chills, malaise, muscle aches, and fatigue. Which is the following is the most likely treatment that was initiated? A, intravenous methylprednisolone. B, rituximab. C, glutamater acetate. D, interferon beta. Or E, nitazoxanide. The answer is D. So interferon beta. The interferons frequently cause flu-like symptoms, and this is a very common side effect which requires intervention. Side effects can usually subside after early treatment. They last about a day after injection and may subside over time. Nonsteroidal anti-inflammatories and Tylenol are often used to manage the symptoms. Question 15. 60-year-old mechanic fractures his left tibia. 2 weeks later, he develops severe constant aching in his leg. The leg becomes pale with some cyanotic mottling. He feels cold and sweaty, and movement is limited. Toenails are brittle and short. So the most likely diagnosis is A, tarsal tunnel syndrome, B, occlusion of the tibial artery, C, as psychophysiologic disorder, D, complex regional pain syndrome, or E, a dermophyte infection. The answer is D. Complex regional pain syndrome, or reflex sympathetic dystrophy, is a progressive disorder caused by severe pain, swelling, and changes in the skin. The cause of this disorder is not known. Precipitating factors include trauma and surgery, although there are some cases that have no demonstrate injury originally. And it's characterized by presence of noxious event causing some sort of immobilization or nerve injury, continued pain, allodynia, that is pain to perception of pain to something that should not be painful, hyperalgesia, and evidence at the time of sometime during the course of edema, changes in blood supply or abnormal pseudomotor activity in the area of the pain. And here's a picture showing the left leg having be swollen with discoloration. All right, good luck.